And it is my honor and my absolute pleasure to introduce in this concluding remarks, Dame Mary Archer. We are actually very lucky to count a lot of what she has done as being directed to women and to health care. She is with us today to help us close this conference with a sense of the importance of urban women's health issues and looking ahead to the future of health and healthcare in London and beyond. And again, whatever we heard today about London, we hear it about we also know that it affects different parts of the world. Dame Mary spent many years chairing the Cambridge University Hospital's NHS Foundation Trust. She was honored by the Queen in 2012 in recognition of her extraordinary contribution to healthcare and the NHS. In addition to managing both Addenbrooke's Hospital and the Rosie Hospital, the Trust is also leading a national center, is a leading national center for specialist treatment for rare or complex conditions, a government-designated biomedical research center, one of only 5 academic health sciences in the UK, a university teaching hospital with a worldwide reputation, and a partner in the development of Cambridge Biomedical Campus. During her tenure at the Trust, Dame Mary led a pioneering NHS-funded initiative to create patient decision aid for patients with localized prostate cancer. She is currently leading a group to create an online PDA and information advice for bladder cancer patients in hospitals and across Angelia Cancer Network. Throughout her career, Dame Mary has dedicated herself to the sciences, having taught chemistry at the University of Cambridge for 10 years before expanding her interest to include solar energy utilization, on which she has published 3 books. Dame Mary is now president of the National Energy Foundation, which she formerly chaired for 10 years, and is also the president of the United Kingdom Solar Energy Society. We're really fortunate to have somebody with her qualifications, her interest in science, her interest in energy, her deep appreciation for art and humanity to be part of our healthcare and to be really thinking about the future. We are so glad to welcome you here today, Dame Mary, and to share your observation. And thank you for being with us all day. And thank you for the support you have given us as we are putting this conference together. Ladies and gentlemen, Dame Mary Archer.
Afaf, thank you for your kind introduction. I should warn you that another less tactful introducer once said to the assembled audience, I dare say those of you who have not heard Mary Archer speak before will be looking forward to hearing her speak now. I'm honored by the invitation to speak in this stimulating conference. Although my qualifications for speaking are the same as Ruth Carnell's, that I am a woman and that I live in a city. Otherwise, they're slender. I have no medical or nursing background. As I was reminded soon after I got my PhD, when I went to work over the summer at Brookhaven National Laboratory on Long Island. Richard told us that his daughter is called Isabel. I worked on the synchrotron called Isabel at Brookhaven. When she was decommissioned, she got a new name, Wasabel. There I was on Long Island, the amiable porter who helped me carry my luggage up to the girls' dorm. Those were the days when you had girls' dorms. Looked at the luggage labels, which I had on my baggage, proudly inscribed Dr. Mary Archer. And he sighed and he said, "You a real doctor, missy, or you kind of doctor never did no good to nobody." I had to admit I was the latter kind of doctor. And years later, I found the complexities of chairing a major teaching hospital with over 1,000 of the real sort of doctors to be considerable, requiring every skill I had, as well as quite a few I didn't. But although I'm not a real doctor, and only the kind of self-taught nurse that every mother and grandmother becomes, I can say something about healthy cities for healthy women, from the perspective of being a woman living in a major city with considerable personal experience of healthcare, organizational experience of the NHS, and an abiding interest in international and global health issues. We're gathered together in the splendid Georgian house that is now Mayfair's Millennium Hotel. And thinking about what I would say today, that put me in mind of the Millennium Development Goals. It's striking that of these 8 goals, no fewer than 3 relate specifically to women. These are to promote gender equality and empower women by eliminating gender disparity in education, to reduce child mortality in children under the age of 5 by 2/3, to improve maternal health by reducing maternal mortality by 3/4 and achieving universal access to reproductive health. The UN didn't seek my advice when framing these 8 Millennium Goals, but if they had, I would have added a 9th that resonates with women's role both as daughters and as the world's main caregivers to the elderly. And that additional goal would be to improve the care of the elderly by healing the deep division between healthcare and social care that exists in many developed countries today. So I'm going to look at women's life course in terms of those 3 official Millennium Goals and my own unofficial Millennium Goal, and at how the city in which women live help or doesn't help her personal achievement of those goals. So looking first at the Millennium Goal of promoting gender equality and empowering women by eliminating gender disparity in education, let us, the empowered women in this room, if I may address you, first of all acknowledge the happy accidents of birth and upbringing that have given us all access to a good education, the most priceless gift that parents or the state can give to any child, and one that is still denied to girls in large areas of the world. As Malala Yousafzai, the Pakistani girl shot in the head on a school bus by Taliban gunmen because of her campaign for girls' rights to education, said in her awe-inspiring speech to the UN, "Let us wage a global struggle against illiteracy, poverty, and terrorism. And let us pick up our books and pens. They are our most powerful weapons. One child, one teacher, one pen, and one book can change the world. Education is the only solution. Education first." And she said that on her 16th birthday. But we have to admit that the education of women didn't come first, even in the developed world, until quite recently. The sponsor of this conference series, the creator of this conference series indeed, the University of Pennsylvania, has always been progressive in outlook and was a trailblazer in this regard. Penn first conferred degrees on women in 1880, and women were admitted to the graduate school from its inception in 1882. That contrasts favorably with the University of Cambridge, where I taught for some years. There, a small band of determined women, joined by a few enlightened men, had started private university-level teaching of women in the 1870s. These female students were permitted to take the university examinations, separately from the men, of course, and on an unofficial basis, as early as 1881. But if they passed those examinations, they were not permitted to call themselves Cambridge graduates, and they emerged from the two women's colleges at Cambridge, Girton and Newnham, with a mere college certificate, not a Cambridge BA. Early attempts to secure degrees for women in Cambridge were rebuffed in 1887 and again in 1897, when male undergraduates demonstrated against the higher education of women by burning the effigy of a woman in blue stockings, the academic kit of those days. If you live here in London or are staying here in London, you might want to see the play Blue Stockings, which returns to the repertoire at Southwark's Globe Theatre in early October. It tells the story of those times and the courageous young women at Girton who risked not only their reputations and their marriage prospects for their university education, but also, according to the celebrated British psychiatrist Dr. Henry Maudsley, their very sanity. In 1874, he wrote a paper entitled Sex and Mind in Education, in which he argued, mental taxation in a woman can lead to atrophy, mania, or worse, leave her incapacitated as a mother. This is not an opinion, it is a fact of nature. My Cambridge college, Newnham, has a story like Girton's to tell, as exemplified by the formidable Philippa Garrett Fawcett. Philippa was the daughter of the suffragist Millicent Fawcett and the niece of Elizabeth Garrett Anderson, the first woman to become a qualified doctor in England. So Philippa came from fighting stock. In 1890, as a Newnham student, she became the first woman to obtain the top score in the very tough Cambridge Mathematical Tripos examination. But she didn't receive the coveted title of Senior Wrangler, the name given to the individual who comes top of the mathematical tripos, because only men were ranked, with the women being listed separately. When the women's list was announced, Philippa was described as placed above the Senior Wrangler. Coming amidst the women's suffrage movement, her feat gathered worldwide media coverage, spurring much discussion about women's capacities and the validity of Dr. Maudsley's opinions. It also inspired this limerick from a less successful male undergraduate who tackled the tripos. I spent all my time with a crammer and then only managed a gamma. But the girl over there with the flaming red hair got an alpha plus easily. Damn her. Degrees for women in Cambridge went down to defeat yet again in 1921. And this time, the male undergraduates celebrating victory over women used a handcart as a battering ram to destroy Newnham's beautiful bronze gates, a memorial to the college's first principal, Annie Jemima Clough. When men resort to violence, it's so often because they've lost the argument. But things move slowly in our ancient universities, and it was to be 27 years later, in 1948, that women were granted Cambridge degrees. Investing in the education, excuse me, investing in the education of girls and women is a proven way to improve the health and wealth of a whole nation. And Cambridge has atoned for its late recognition of this by being the proud host to CAMFED, the Cambridge Female Education Trust, which focuses on areas of Africa where poverty is widespread and girls and young women faced massive exclusion, thank you so much, from education and the opportunities that are afforded by education. Since its foundation 20 years ago by Anne Cotton, CAMFED has provided 1.5 million girls with access to safer, improved school environments, and over 50,000 girls with comprehensive support throughout the full 4 or 5 years of their secondary education, the time when most girls are lost to education through poverty, but where the highest gains in terms of future health and prosperity are achieved. The title of this conference is Healthy Cities, Healthy Women. But in thinking about it, I turned it round in my mind to healthy women, healthy cities. Because if women are healthy, their families are healthy, and their communities will also be healthy. So does the way healthcare is provided in London help women to remain healthy throughout their life course? Not really, despite the good intentions of the NHS. As someone who owes her life to the NHS, I was diagnosed with aggressive bladder cancer in 2010 and am now the proud possessor of a beautifully constructed bladder out of 0.5 meter of my small intestine, provided by the NHS. I have been saddened to see the NHS under intense criticism recently as a result of the Francis inquiry into events at Mid Staffordshire Hospital. This uncovered serious defects in the standards of care at some of our hospitals. At the same time, I have to say, as it challenged the nation's journalists to understand the statistics of normal distributions of mortality and morbidity. I rather liked this from the Guardian newspaper, wringing its hands about the link between social deprivation and health outcomes. 50% of obese people, 50%, earn less than the average national income. A couple of years ago, the Royal College of Obstetricians and Gynecologists, which is just up the road from here in Regent's Park, brought out a paper about how the NHS might adopt a life course approach to women's healthcare. It made the point that Ruth Carnell made so powerfully this morning, that healthcare today, at least in this country, is episodic, dealing with the present issue and not what might lie ahead or what lay in the past and is influencing the present. Although this is clearly less than optimal for both men and women, it presents more of a challenge in women's healthcare than in men's, because women have more predictable healthcare needs than men, and if they have children, more frequent interaction with the health services. That brings me to my second Millennium Goal, which is to reduce child mortality in children under the age of 5. Here I should acknowledge the role of our other conference sponsor today, The Lancet, which since its foundation 180 years ago has been a reformist and campaigning medical journal. In recent years, it has focused on child survival, not only in the crucial first days and month of a baby's life, but in children up to the age of 5. Globally, encouraging progress has been made with child mortality in recent years. A new report from the World Health Organization says that the number of global deaths among children under the age of 5 is now only about half what it was 22 years ago, though more needs to be done to reduce health inequalities. A child born in sub-Saharan Africa faces more than 16 times the risk of dying before his or her 5th birthday than does a child born in a wealthy country. One country that has achieved the child mortality Millennium Goal is El Salvador. Liz Campbell, the CEO of the excellent charity Wellbeing of Women, is with us today, and that gives me the opportunity to acknowledge and thank Wellbeing for their support of the charitable work of Addenbrooke's Abroad in El Salvador. Addenbrooke's Abroad is a charity which I helped to found at Cambridge University Hospitals in 2006. And since then, it's supported hundreds of the hospital's staff and students in volunteering their skills in resource-poor parts of the world. We have a link at government level with the Ministry of Health in El Salvador, where Wellbeing gives us crucial support in a nationwide program to improve the health and care of women, mothers, and babies. And Liz, I think between us, Addenbrooke's Abroad and Wellbeing can take considerable credit for El Salvador's achievement of the child mortality Millennium Goal. Because when we went there, doctors did not attend women in labor in public hospitals, nor was there any specialist nurse like a midwife. There was no such discipline. Addenbrooke's Abroad's other main overseas link is with the government of Botswana, where PEN is also doing great outreach work through the Botswana-UPenn partnership, which aims to improve the clinical care of HIV-infected and affected persons. In the UK, child mortality is low, though it can always be improved, and maternity services are generally of good quality, but they can be disjointed. Despite all the evidence showing that a woman's health in the preconception period and during pregnancy has enormous impact on the future health of both herself and her child, contraception, preconception, and antenatal care are seldom provided by the NHS in a joined-up fashion. Although through these services, women have multiple encounters with nurses, midwives, general practitioners, and obstetricians who would be well placed to deliver consistent health messages and more holistic care. The internal market in the NHS, that is the organisational separation between the commissioners, the purchasers of healthcare, and the providers of it, such as hospitals and GP practices, was introduced by Margaret Thatcher's government way back in 1989. And it's undoubtedly increased efficiency in the use of resources in the vast monopoly that is the NHS. However, it can lead to adversarial behaviour and arguments about money rather than about the quality of care that is provided. For example, pregnant women are screened for their risk of venous thromboembolism in the community by midwives. Fewer than 1% of women are found to be at risk, and these women should commence low-dose, low-molecular weight heparin, for the duration of their pregnancy and for 6 weeks after delivery. But until recently, a number of commissioners wouldn't fund heparin for those at-risk pregnant women. It's therefore helpful that NHS England, a new body which now oversees all commissioners, has mandated that NICE approved best practice, which includes heparin, for at-risk women, must be followed in this and other respects. Then there's the role of GPs, or rather the lack of it, in the care of pregnant women. The move of antenatal care from GPs to midwives, which came about with the Changing Childbirth initiative of the early 1990s, had the laudable aim of creating a woman-centered service. But it's had the, no doubt, unintended consequence of separating GPs from their pregnant patients. In most parts of the country, GPs have now virtually no role in antenatal care other than to confirm pregnancy, largely redundantly because women do this at home themselves with those kits you can buy. So there's little opportunity for GPs to share important information about their patients with the midwives and obstetricians who will look after them through that birth episode. And they will have to reconnect with those patients once they've delivered and come back to their GP with all the health niggles that their new baby may have. It's essential to ensure, looking at it the other way, that GPs are alert to the reproductive histories of their patients. For example, roughly half of the women who experience gestational diabetes will go on to develop type 2 diabetes within 10 years. And the 10% of women who have hypertensive disorders in pregnancy have twice the risk of future cardiovascular disease. The development of evidence-based guidelines for screening this large group of women has now been undertaken and should help to reduce the risk. There's also the issues that pregnancies that aren't going well for the baby may not be picked up by a system that tends to start with the assumption that all pregnancies are normal. Whereas, in fact, 1 in 5 pregnancies in the UK ends in miscarriage, and 17 babies a day are either stillborn or die shortly after birth. Stillbirths, I think, are an under-researched area. At 1 in 200 births, stillbirths are 4 times as common as Down syndrome, and yet the methods for assessing a woman's risk of having a stillborn baby by measuring the size of her bump and whether the baby is progressing are medieval as compared with the now sophisticated methods by which Down's pregnancies can be detected. Turning to children, the organizational separation of community, primary and secondary healthcare services has been a long-standing problem in London. A couple of years ago, the London Specialised Children's Services Review reported that children's services in this city are disjointed and provide poor care when compared with other cities, both nationally and internationally. This means that the children of London with complex medical conditions are not receiving the care that best meets their needs. As was noted earlier, mothers often have to take their children to 3 or 4 different hospitals for different parts of their diagnosis and treatment. So it's good to see reform finally afoot, with 2 specialised children's service networks being set up in London, one to serve the north and the other the south. And may they have the same success that the stroke network that Ruth Carnell set up in London has had. Turning to the 3rd Millennium Development Goal that I mentioned, achieving universal access to reproductive health, the UK does not have a particularly good record. Indeed, 15 years ago, the UK had the highest rate of teenage pregnancy in Europe, at 46.6 per 1,000. And the Department of Health produced a strategy for halving it. They have not succeeded. The latest figures show a welcome but only 25% reduction in births to teenage mothers, reducing the UK level to below that of some, but by no means all, Western European countries. That means that about 40,000 young women, that is below the age of 18, become pregnant each year in the UK. 3/4 of those pregnancies are unplanned, and about half end in termination. Leaving aside the considerable resource implications for the NHS and social services, teenage birth is known to lead to poorer child health outcomes, poorer maternal emotional and health well-being, and an increased chance of both mother and child living in poverty, all factors that contribute to health inequalities and child poverty. So reducing the rate of teenage pregnancy remains an important quality target for the NHS, and one focus of the work of Judith Stevenson, who is Professor of Sexual and Reproductive Health at University College London. Judith looks at different forms of contraception, not from the purely medical perspective of how effective they are, but also from the patient's perspective of how acceptable they are in use. There is, after all, little point in medical science developing new drugs and devices if the patient's experience of them, and therefore compliance with them, is poor. Skipping lightly over women's middle years, the joys of the menopause and middle-age spread and so forth, brings me to my own Millennium Development Goal of improving the care of the elderly. We live in an aging society. The over 65s, of which I'm a relatively new member, are now the fastest growing age group in the world, and women with their longer life expectancy are in the majority in this group. In Europe, there are now about 3 women for every 2 men between the ages of 65 and 79, with over twice as many women as men over the age of 80. Although, or perhaps because, women live longer than men, they suffer a greater burden of unhealthy life years. And often older women aren't offered all the available health options. For example, NICE's clinical guidelines say that all women should be offered breast reconstruction if they have a mastectomy, unless there are clinical reasons why they wouldn't be suitable for this. However, nationally, only 1 in 34 women over the age of 75 does have breast reconstruction following a mastectomy, compared with 2 women out of 3 aged under 75. It's hard to believe that this striking difference is purely a matter of patient preference. Then there comes a time in the lives of many older women and older people in general when hospital, social, or residential care is needed. More than half of hospital inpatients are aged over 65. In Addenbrooke's Hospital, the average age of patients in the elderly care wards is 87, and the majority of those are women. Many will need social care, that is, assistance at home with everyday tasks, or residential care when they leave hospital. In England alone, 400,000 people live in residential care. Women are again, of course, in the majority in those care homes, and they also constitute the overwhelming majority of the workforce that work in them. So healthcare and social care desperately need to work in tandem, but they don't. There are great difficulties with marrying the NHS, taxpayer-funded and universally free at the point of need, with means-tested access to social care, the more so in a time of continuing deep cuts to local council funding, because that is where the funding for social care comes from. Hence, government initiatives to join up health and social care better are to be welcomed. On the regulatory front, the Care Quality Commission and NICE both now have overarching responsibilities for the quality of both health and social care facilities. On the service front, the recent NHS reforms are encouraging some innovative approaches to elderly care. In my own county of Cambridgeshire, for example, the Clinical Commissioning Group has just announced the qualifying bidders for an £800 million 5-year contract to provide an integrated, acute and community pathway for older people. The remit will cover community services, responsibility for patients who are admitted to hospitals as an emergency, older people with mental illnesses, and end-of-life care. That will be a remarkable change. Kaiser Permanente comes to King's Lynn. This morning, Ruth Carnell opened the conference by talking about the political challenges and opportunities facing London in the reconstituted NHS. Tackling health inequalities in London is a major challenge, and it's good to know that Ruth, with her enormous knowledge of the way the NHS works in London, has joined the Mayor's excellent team. May I end the conference by saying it has been a privilege to be here today and to speak to you. This conference series is doing its bit for another Millennium Development Goal, developing global partnerships for development, and I wish it every continuing success. As for the other Millennium Development Goals that I discussed, let us hope that they will be achieved rather faster than the University of Cambridge managed in the matter of women's degrees. Let us rather aspire to the speed of the University of Pennsylvania.
Thank you, Dame Mary. Your inspiring remarks remind us that women today stand on the shoulders of our four-sisters, as well as charging us to begin a dialogue. Quote, "A woman is the full circle. Within her is the power to create, nurture, and transform. Today, we've all become part of a shared and ongoing commitment to urban women's health, and now have the opportunity to remain involved and active in an effort to make London healthier and safer. We hope that today renews a call to action, not only to deal with challenges facing women's well-being in London, but also to view women as the catalysts for change. I hope that you will look around this room and walk away with at least one new contact, one new idea, and one new resolution to act on an issue or an opportunity. Please join me in thanking all of the partners who helped make today possible. A special thank you to the Penn team who came over from Philadelphia, who's ensured the success and made this entire day run smoothly, especially to Vice Dean Wiley Thomas. I'd like to thank our conference supporters, the Mayor of London and the Lancet, as well as, fellow conference supporters Dean Kaler, Professor Helen McCutcheon of King's College London, Florence Nightingale School of Nursing and Midwifery, members of the Planning Committee, Dr. Horton, our keynote speakers, Dame Ruth Carnell, Dr. Helen Walters, Dr. Richard Horton, Dean Afaf-Maliz, and of course, Dame Mary Archer. And to all of our panelists and moderators, thank you. There are specific groups at Penn I need to thank as well. the University of Pennsylvania School of Nursing, the Trustees Council of Penn Women, as well as Penn alumni. I hope you all will continue to support Penn Center for Global Women's Health and future Healthy Cities, Healthy Women events. My heartfelt thanks to all of you for showing.